Thank you very much, Marcia. It's great to be here. She didn't mention I had my own health. I've just come back from about being away for 6 months going through treatment for leukemia. So I've had a bone marrow transplant from my sister who's 12 years younger. So I'm now invigorated and more determined than ever. So it really is great to be here. I've been doing breast cancer care and advocacy. I added it up when I was on the plane for over 32 years. And my recent experience really has led me to assess sort of what we've accomplished and what we really haven't accomplished. And I must say we've accomplished less than I had hoped. When I started 30 years ago, and it's interesting to look at this history because it shows you how science and medicine evolves. When I started, the theory was that breast cancer started in the breast, then it got slowly bigger, and then it went one by one up the lymph nodes, and then it got out. And the goal was early detection, get there before it gets out, slam the door so none of those cells get out, and then you'll be cured. And we thought, and the way we did that was with surgery, and more was always better. So we were doing radical mastectomies and even extended radicals where they took out pieces of ribs to get to the lymph nodes under there, thinking that we could really, if we slammed all the doors all around it, we were going to, isolate this cancer and we would cure it. It was a great theory. It just didn't work that well. But that theory led to the idea of early detection and mammography. And indeed, with mammography, they were able to show a decrease in deaths from breast cancer of about a quarter, about 25%, which was very significant. I mean, that's great. Unfortunately, no matter how good mammography's gotten, it's still 25%, and we'll come back to that. So the idea that every cancer could be found early and cured was really starting to be questioned a little bit. And it seemed like some of them we could do it, but a lot of them really, no matter, even if they did everything right, they were still further along than we would have liked them to be. So after moving from or seeing that, we came up with a new theory, and it was actually a dashing Italian surgeon, Veronese, who had they like breasts a lot in Italy, and so he was the one that came up with the idea of lumpectomy and radiation and saving the breast. And he did a study where he compared just taking the lump out and radiating the breast to doing a radical mastectomy. So women were randomly put into one group or the other. Now, allegedly, they knew they were being randomized. I'm not sure he really told them, to tell you the truth. But he would tell them, you need to get a mastectomy, you need to get lumpectomy and radiation. And then after a period of time, they looked at him, and there was no difference in the outcome. So the radical mastectomy was no better than just taking the lump out and radiating. Well, this made us really pause and say, what is going on? If more isn't better in terms of surgery, then there must be something else going on. And what they realized was that for most of the tumors, a very high percentage of them, there were a few cancer cells that got out early on. And so cutting the breast off was really, and a radical mastectomy was really slamming the barn door after and locking it after the horse was already down in the field. That you could do as big an operation as you wanted, but if those cells were already out there, it wasn't going to make any difference. And so what you were doing in the breast was really just preventing breast cancer from coming back in the breast. And if no cells had gotten out, or if your immune system hadn't taken care of them, then it would come back again somewhere else. And if they hadn't gotten out, then you would be okay. So the emphasis shifted from surgery and doing a lot of surgery being the key to what can we do for those cells that got out. And that came up, then that's where we came up with doing chemotherapy after the surgery. So we would do the surgery, and they did a study where they randomized women then to either get chemotherapy afterwards or not. And lo and behold, adding the chemotherapy to the surgery made a significant difference. Not in everybody, but it made a significant difference. And why? Well, because it took care of a lot of those cells that had gotten out. So now anybody who had a big cancer or had lymph nodes or had anything we thought was bad, we would give them chemotherapy in addition to surgery. So you could save your breast, but if the surgeon would let you. I mean, as an aside, the Italians did the study and showed it, and we were telling women they could have lumpectomy and radiation, but the American surgeons were saying, no, that only works in Italian women with Italian breast cancer. American women need radical mastectomies. And so then Bernie Fisher did a study in American women with American breast cancer, and lo and behold, showed the same thing. Surprise, surprise. So now we have surgery and chemotherapy, and we also found that some cancers were sensitive to hormones. And so then tamoxifen came into the picture, and tamoxifen is an estrogen blocker, and so tamoxifen in addition. So then you either got hormones and chemo, or just hormones, or just chemo, but you always got something, almost always got something in addition. But still women were dying of breast cancer. So here was this great theory. We're really good on theories, and we're making a little bit of progress each time. We're chipping away at it, but still a lot of women were dying. So we decided it was because we weren't giving enough chemotherapy. So the problem with how much you could give was the bone marrow. So chemotherapy kills cells that are dividing rapidly, and the cells that are dividing rapidly, besides the cancer, are hair, which is why your hair falls out, as well as your blood cells, which is why they check your blood all the time. Excuse me. I can see the answer to my problem right here. So we said, and just about that time, they had figured out how to do bone marrow transplants. So they said, aha, we got an idea. We'll take the woman's bone marrow out, stick it in a freezer, blast the hell out of her with chemo, so we'll kill all the cancer cells, and then give her back her bone marrow. So we'll protect the bone marrow while we blast her, and that way she can survive this really high-dose chemo. So that was the era of high-dose chemo with stem cell rescue, which was the early 90s. And it seemed that that was going to be the answer. And really, it was very popular. Women were suing their insurance companies to get it. And it was also very toxic and really hard to go through. And then finally, a randomized controlled study was done. So you notice, if we don't do the studies, we never make any progress. Where they randomized women to either get their high-dose chemo with stem cell rescue or not. And lo and behold, there was no difference in breast cancer survival, but more people with a transplant died of complications of the transplant. So again, another theory out the window, more isn't better in terms of chemo. So if more isn't better in terms of surgery and more isn't better in terms of chemo, what is the answer? And so the next wave really was figuring out that all breast cancers weren't the same. And this was a big revelation, that you could actually break it up into 4 or 5 different groups. So there was one group that was sensitive to hormones, estrogen positive. There was another group that was estrogen negative. And of those, some of them had an extra growth factor and some of them didn't. So you could put it into different categories. And really, the success that pushed everything along was Herceptin. And at UCLA, Denny Slayman, who Dr. Pegram and I worked with early in the days, I found out that some cells had too much of a growth factor called HER2/neu. I'm not quite sure where they got that name, because it always sounds to me like something you should put on your hair. And my hair looks better since I used HER2/neu. But it's not. It's actually a growth factor that tells the cells to grow stronger, harder, faster. And the women who had extra copies of this growth factor had more aggressive cancers and were more likely to die. And they were able to develop an antibody to the growth factor, which is Herceptin, that would block it. And when you did that, these women who really had a very aggressive cancer did much, much better. And this was the new era of, well, gee, maybe just poisoning the cancer with chemo isn't the whole answer. Maybe we really can match the treatment to the kind of cancer. So we now had different kinds of breast cancer, different flavors of breast cancer. The hormone positive one, the hormone positive but HER2/neu positive one, the hormone negative one with HER2/neu, and then one that was hormone negative and HER2 negative, which is called triple negative. It's sort of a bad name because it sounds like it must be 3 times as bad as anything else. But it really isn't. It's just that when you write it down on a piece of paper, you write estrogen negative, progesterone negative, HER2/neu negative, so there's 3 negatives, so you say triple negative. And the triple negative cancers tend to be more sensitive to chemotherapy than any of the others. So it's gotten a sort of a bad reputation, but it actually, chemotherapy works better in those cancers. So then in this era, we're doing hormone therapy, tamoxifen or aromatase inhibitor for the hormone positives, and we're doing chemotherapy for the triple negatives, and Herceptin plus chemotherapy or Herceptin plus hormones for the ones that have too much. So it's a match up the right kind of treatment, and that actually has made significant progress. Not perfect, and there are tests now that you can tell whether you need chemo or not. The Oncotype DX test will tell you some tumors where chemo's really not going to add anything, and so you don't need to take it, and hormones are fine, and some tumors where you really need both. So that's good. But you notice in this, we keep adding new things. We never subtract. We have surgery, then we add radiation to the surgery, then we add chemo to the surgery, then we add Herceptin to the chemo to the radiation to the surgery. We never subtract anything. And so then that, as I'll talk more about in the panel, leads to an increase in complications and in collateral damage and in side effects from the treatment, which I think is not discussed enough. Well, now where we are, and it's really because of Herceptin and HER2/neu, is in the era of the gene. We now think that if we just analyze the cancer cells enough, we will find every mutation that the cancer cell has, and then we can find a drug to match that mutation, just like Herceptin can block the HER2/neus, and then we'll be fine. So they did the TCGA, the cancer, TCGA, the Cancer Genome Atlas, yes, and TCGA are the 4 nucleotides in DNA. So somebody spent a lot of time in the back room coming up with that acronym. And what they're doing is mapping every mapped every pathway, and they found some interesting things, and they can make some interesting subgroups, but we've got a new thing that shows that that's not going to be the whole answer either. And that is last year a study that showed that the tumors don't stay the same. So you could start out as HER2/neu positive and then have metastases that are HER2/neu negative. Or you could start out with one pathway and then end up with another pathway. So the idea that we were just going to find the one pathway and the one treatment was another pipe dream. So it's sort of depressing, but the interesting thing is there's a whole other theory that's come up, which is much more interesting, and to me, I think is more likely to be important, and that is that it's not just the tumor cell that we need to be worried about. That we've focused on just the cancer cell and what's wrong with the cancer cell and how can we kill the cancer cell. But to get cancer, you need more than just a mutated cell. You need a mutated cell that's in a local neighborhood, an environment that's egging it on. And this was shown really eloquently by Mina Bissell over in the Lawrence Berkeley lab, not too far from here, where she took breast cancer cells and grew them on normal breast tissue, and they behaved normally. And then if she put them on cancer breast tissue, they behaved like cancer. So the neighborhood, the tissue it's in, is as important as the cell. So I like to think of it as neighborhood. So in LA where I live, you get a kid who's maybe marginal, and he grows up in South Central LA with gangs and drive-by shootings and drugs and all those problems, he'll probably end up not very good in jail. But you take that same kid and you put him out in the suburbs, and you take him, put him on Boy Scouts, and he's in the band, and he goes to, you know, he has a girlfriend, and, you know, a different environment, and he can turn out good. So the neighborhood can affect how these mutated cells turn out. Well, what's in the neighborhood? Well, we're looking now at the genes in the neighborhood, but it's also the immune system. And, you know, people always said, well, you know, doesn't the immune system have something to do with cancer? And for a long time, we in oncology dismissed that as crazy. And now it turns out that the immune system has a lot to do with it in both directions. One, in terms of preventing you from getting it, but then also sometimes the tumor can hijack the immune system and use it to make it more aggressive. So it can work in both directions. And there are other factors in the neighborhood that can make a difference. So local factors, hormones, for example, and taking the reason that hormone replacement therapy probably increased breast cancer is because it changed the neighborhood. In fact, you could see the mammogram getting more dense after you took the hormones. And people who took hormones had more breast cancers. And as soon as that study showed, the Women's Health Initiative, which Dr. Stepanek was part of, showed that data, women stopped taking it, and you could see the number of breast cancers going down. Well, did they die? You know, those little cells die? No, but they probably got contained and controlled. We probably all walk around with breast cancers. In fact, one study showed on autopsy that 30% of women have breast cancers in their breasts that are doing nothing. And so it's when the neighborhood and the other conditions are right that it misbehaves and that things get carried on. And that's probably true with other cancers as well. So the neighborhood is local, but it's also systemic. And we have data now showing that exercise decreases the chances of getting breast cancer, as well as the chances of getting a recurrence of breast cancer. Now, for a long time, we've known this for a while, but everybody's saying, exercise? How does that, you know, that can't be, you know, how could that work? But what exercise does is it's anti-inflammatory. And so it decreases inflammation, changes, you know, affects the immune system, and probably works by changing the neighborhood of your whole body. I mean, certainly when you exercise, you not only feel better, but I mean, the reason I exercise is you feel morally superior. And that just by itself will change the neighborhood. So exercise works. What you eat probably works by changing the neighborhood. Whether you're overweight or not changes the neighborhood. And we're finding more and more, and stress reduction and meditation changes the neighborhood. Now, none of these things are perfect. It's not like you can say, well, if I just exercise, you know, I'll never get cancer, or I'll just, but all of these things work together to make a difference. And I remember a woman who came up to me in the farmer's market in LA and said, oh, you know, I just got a recurrence of my breast cancer. I had breast cancer 20 years ago. I had a mastectomy. I've been fine. And I just got a lump on the scar 20 years later. And she said, how could that be? And I said, well, what's been going on in your life? She said, oh, it's been a terrible year. My mother, you know, has Alzheimer's. I had to go move her out of her house into an assisted living place. I had to quit my job to do it and get her all organized. It's been just, you know, very stressful. And I said, well, that's probably what's going on. You've had those cells. They've been sitting there dormant for 20 years. And then they just woke up. And so the question, you know, but the good news is, you see, you know, people looking nervous, but the good news is we're probably all walking around with these dormant cells. And if we do all these things that people have been telling you all these years about diet and exercise and stress reduction, those are all things that we can do to maintain the neighborhood. So there is something we can do. I mean, is it going to be perfect? No, nothing's ever perfect. But it can make a real difference in what goes on. So this is all great, and there's a lot more research going on, and they're trying to figure out vaccines from the immune system, or how can we turn the immune system around to make it work better, and how can we change, what are the genes in the surrounding cells to the tumor, and that's the wave we're in the middle of now. But the problem is, with all of these changes and all these waves and all these 30 years, there's still 813 women being diagnosed with breast cancer every day and 110 dying every day in this country. That's a lot. And so, to me, it's fine, all this treatment stuff, but wouldn't it be better if we just didn't have it in the first place? I mean, that's really where we need to go. And what's interesting is, over these same 30 years, we've seen this happen in cancer of the cervix. So in cancer of the cervix, when I was in training, if you had an abnormal pap smear, you had a total hysterectomy, because we didn't know what else to do. And then we figured out, oh, you could do something local and maybe preserve the person's fertility. You could do cryo or laser or something like that that was less invasive, so they still would be fertile. And then we figured out that it was sexually transmitted and that it was a virus, and now we have a vaccine. So in 32 years, we went from cutting out normal body parts to prevent a disease to having a vaccine that'll prevent it entirely. That's pretty amazing. That's really great. And yet, what happened yesterday? We heard that Angelina Jolie cut off a normal body part to prevent a disease. In breast cancer, the only, the really reliable prevention is to cut your breasts off. Well, that's terrible. So we really need to shift, I think, from all these treatments and trying to figure out treating it to what causes it and how can we prevent it? Because that's, I think, where really we're going to be most effective. Now, the drug companies don't always agree with that, because that everything pushes on that side. Let's give more treatments, let's give more drugs. But really, all of those drugs and all of these treatments have significant collateral damage on your body. From the chemo brain to the numb feet to the fingers that tingle, they have all kinds of side effects. And the chemo can increase second leukemias, it causes heart disease, the radiation can cause second tumors, the hormones cause joint pain and cause other problems. None of these are a free lunch. So if we could just prevent it entirely, we could have it would be much better. And that's, I think, where we really have to shift the research. And so we're doing some studies at the Dr. Susan Research Foundation to try to see, could it be a virus? There's a mouse that has a mouse mammary tumor virus that causes breast cancer in mice, and maybe it could be. We're looking in the breast fluid to see the breast duct fluid to see what's growing there. So we did a study on 60 women, and we're going to analyze it. The way we used to do it is we'd take the tissue, grow it on a Petri dish, and then see what grew out. But that depends on what's in the Petri dish and how long you put it in the incubator and all the conditions. And maybe there's a bug, but it wasn't in the right conditions. Now what you do is you just take the fluid and you look at all the DNA that's in the fluid, get rid of the human DNA and see what's left. And then you say, oh, that's who's there. And it probably, whenever you have an organ that's sucked on by babies and lovers and it's not going to be sterile. There are bugs in there. I'm sorry. We don't like to think about it, but there are bugs in there. And so let's see if maybe it could be a virus. Because if it were a virus or a bacteria, we could get a vaccine or we could find a treatment for it. So that's one pathway. And there are other people looking at other pathways of trying to figure out what the cause is. But I think we have to do that. And so another way we're trying to do that is we have the HOW study, the Health of Women study, where we're tracking women over time to see if we can find risk factors that haven't really been noticed before. And you can sign up and be part of this. It's an online study. Every quarter, every 4 months, you'll get a questionnaire to fill out. And we're going to track over time. And if you have any hypotheses or ideas, you can give them to us. We'll ask your question, too. Because, the answer could be something. Somebody told me the way they figured out cancer of the cervix was they noticed that this guy, his first wife died of cancer of the cervix, and then his second wife died of cancer of the cervix. And they said, maybe it's the guy. And so you know, those kind of observations you could have too. You don't need to be a scientist to notice that. So you can ask the questions as well. So you can go, if you go to actwithlove.org, you can see where the How study is. You can sign up. And we want women with breast cancer and without breast cancer. Because if we don't study the women who don't have it, we're not going to, you know, we have anybody to compare to. And we need all ethnicities, all ages. Because if we only study, you know, one ethnicity, then it's not going to tell you what's going on. So we need everybody. So that's one thing you can do. You sign up and then get everybody you know to sign up for that. It won't cost you any money. You'll be part of the solution as opposed to just sitting there worrying. And that's really one of the things we need to do. And then you can join the army of women. And this is what was alluded to earlier, but we now have 371,000 women, not just breast cancer survivors, a lot of women who are not breast cancer survivors, but are willing, I mean, it's not that they didn't survive. They haven't had breast cancer, is what I mean to say. But they're willing to participate in research to find the cause of breast cancer. So they sign up to get emails from us about different studies. Researchers come to us with their studies. We have a committee that looks them over, makes sure they're legit and they're not doing something really crazy. And then we e-blast it out to everybody. So we don't just send it to the person that fits. So it might be a study in San Francisco. We'll send the announcement to somebody in Kansas because they may have a sister or a cousin in San Francisco. So every time we send it out, it gets virally sent out further. And we've recruited for a number of studies here up at Stanford very successfully on chemo brain and some side effects of breast cancer and, treatment. And I thought that having this army of women would really be the answer. And I must say, to get scientists to do more research on women. But I must say, it's going to take more than that. They're still addicted to rats and mice. And the trouble is, rats and mice really are not the same as women. I know it's a big shock to you, but they're not the same. We're not the same as rats and mice. And I thought it was because the researchers didn't know how to find women, so I'd find them for them. But no, it's that they really like rats and mice because they're easier. You can control everything. You know, you can control all the different elements, and it's nice, pretty science. It just doesn't have anything to do with our health, but it has to do with the health of the rats and mice. But not us. So we need to really start studying women and healthy women. You know, the final thing that really makes me crazy is that we don't understand the normal breast. That, believe it or not, we still don't know, you know, breast cancer starts in the milk ducts, but we don't know how many milk ducts there are. We don't know how many holes there are in the nipple. Nobody has ever done a study to count them. Now, we did one, and we say there's 6 to 8. You know, all of you who have breastfed know it's not a hose, it's a watering can, that there's a lot of different holes. And we have one, but people who cut the nipple off say there's 22 to 25. I think they're wrong, but we need more research on this. And what does the breast do when it's not making milk? Just hang out, you know? Actually, it makes its own hormones. You know, women who are postmenopausal often get hormone breast cancer, estrogen positive, even though their ovaries aren't making much estrogen. Well, that's because the breast's making it. And it may be making it differently in different ducts. So it may be that it's not the breast that's a disease, but just one duct in the breast. See, maybe the unit we should be studying is the duct. And then when we talk about the environmental carcinogens, we don't know if they even get in the breast, much less in the breast fluid where breast cancer starts. So shouldn't we be looking at what can get into the duct and what can't get into the duct? We've tried to get a grant to do this several times and not been successful, but we'll keep on trying because we're not going to figure out what causes breast cancer until we understand the breast. You'd think with all the DNA and fancy genetics and molecules and mutations, we would know something about the anatomy and how the non-breastfeeding breast works, but we really don't. And that's a whole area that's been ignored. So it's another thing we have to push people to do, not just look at the disease, but see what is normal. Because if we're going to find the cause, if we're really going to prevent it, we have to understand how it works. And to do that, we have to do more research on healthy women and be able to compare them to women who get cancer and try to figure out what are the early things that go wrong. What are the early changes? Are they making too much hormones? Are they making too little hormones? We did a study where we actually tested ductal fluid from 3 different ducts of healthy women, and then 6 months later again. So we did it twice, the same 3 ducts. And we looked at estrogen and progesterone hormones and compared them duct to duct. And they weren't the same. Each duct had different levels of hormones. And 6 months later, they were different in the same duct. So the breast is having a whole thing going on continually. It's not, just sitting there hanging out. It's making hormones and one duct's changing and it's doing this and somebody else is responding to that. There's a whole party going on in there. And it's no wonder it, gets screwed up. So we have to figure those things out or we're not going to figure out what causes breast cancer. So my big thing, and what I said to the New York Times is, isn't it a shame that the only thing that Angelina Jolie has to do with knowing she has a gene is to have a normal body part cut off? Because we don't know how to prevent breast cancer. And we don't know what causes breast cancer. And shame on us. So that's really what we're trying to do at the Dr. Susan Love Research Foundation. We're trying to shift all of that. Now, if you want to be in the army of women, I have this thing here. You can text on your phone 444-999 and join right up, right now. Or just write it down, 444-999, and you'll join. Or you can go to actwithlove.org and sign up. You'll get emails from us about different studies, and you don't have to do them. If you look at one and you don't like it, you just don't respond to that. But if there's one that fits you that you like, you respond to it. Or if you know somebody, you respond to it. And if we're all in this together and we're all pushing the scientists and helping the research get on, then maybe we will get to a point where we can figure this out. So I urge you to, we've been running, we've been walking, we've been wearing pink, and I do think that when the NFL is wearing pink, we've got awareness. Awareness has been accomplished. I think we don't have to work on that anymore. What we have to work on is going beyond awareness to being part of finding the solution, both demanding better research and being willing to sign up and be part of it whenever we can to push things forward. So with that, you have your marching orders. I expect to see a bump in the Army of Women numbers coming from the Menlo Park, Stanford area when I get back. And then I'll know you really got the message. And with that, I think we can be the generation that ends breast cancer. Because if we don't do it, it's just going to continue on. So it's our job, and here we are. Let's get on with it. Thank you.